Hello, my name is Ravi Vij. I'm from My Cancer Haven. And today I have with me Dr. Charanpreet Singh, who's assistant professor in clinical hematology and medical oncology at the PGI Institute in Chandigarh, India, one of the premier institutes in India for hematological malignancies. And we're going to talk about chronic lymphocytic leukemia, especially providing an Indian perspective. So, welcome, Charanpreet.
Hi, Dr. Vij. Thank you so much for having me. It's a pleasure to be here.
So, just to get the ball rolling, so what is chronic lymphocytic leukemia?
So, what I normally tell patients is that the name leukemia is scary, but CLL is not scary. CLL, as the name suggests, is a chronic lymphocytic leukemia. So, it's a chronic, slow-growing proliferation of the B cells, which, like you mentioned on the slide, is the most common leukemia in adults in the Western part of the world. That is not the case in India, as far as the data is concerned. I think chronic myeloid leukemia would be much more common than chronic lymphocytic leukemia. In fact, maybe so would ALL or AML also. The problem with the epidemiology is that we don't really know we don't really have too many epidemiological based studies in India. So to get a true estimate of the incidence is really tough. And more as we're starting to have the percolation of health insurance and routine health tests in the population, especially in the those living in urban and semi-urban cities and areas. We are getting more and more patients who are asymptomatic coming to us and telling us, hey, we have this lymphocyte count which is elevated in our blood investigations. What do we need to do about it? And that's how the journey starts many a times. Or they may be just feeling unwell. And here in India, at least, getting a lab test is really simple. And it's getting a CBC is really cheap. Often it's maybe just 30, 40 rupees, which would turn out to be maybe 50 cents in dollar terms. So they just get that blood test, they find that abnormality, and then they'll end up coming to an oncologist or a medicine specialist or a hematologist, and that's how their journey will start.
So, you mentioned briefly in passing about the epidemiology. You said it's not as common as CML. Any other flavor that you can provide?
So, like I said, the data is not there in India because we don't have a registry-based registry for the entire country where uh, all cancers or all diseases would be registered. So it's very tough to make an estimation. The data which is available, which says that maybe CLL is not as common as is what is reported and is definitely seen in a younger population as compared to the West. However, I will caveat that and I will say that right now in my outpatient basis, I do see CLL and lymphoma in my outpatient basis at PGI predominantly. And CLL would be among the top three disorders that I would see, along with maybe diffuse large B-cell lymphoma and Hodgkin's lymphoma. So even though the data may say that it's not really common, I think if you take it into the cohort of maybe all chronic lymphoproliferative disorders and lymphomas, it's actually pretty high and it's probably underreported. We probably have a bias because we are a large tertiary care center and probably one of the only tertiary care centers in this region north of Delhi, which has a hematology and an oncology service. So we get a lot of referrals. So maybe we are seeing more patients than what would be seen in the general population, maybe. But my practice says that it's actually more common than what is reported.
So, you mentioned that a lot of patients just get a routine complete blood count, and that's how their journey starts. So, what else do you do when they reach your door?
So it really depends on what the symptomology of the patient is. So, like I said, if the patient is usually just asymptomatic and has come in with a peripheral with a CBC, which is showing elevated TLC, the first step is obviously to get a good peripheral smear and to characterize whether those are lymphocytes, whether what size they are, whether there are any smudge cells, which can give you a hint that this is probably a chronic lymphocytic leukemia. Prior to that, we would want to do obviously a detailed examination to look at whether the patient has any pallor, any jaundice, any lymphadenopathy, hepatosplenomegaly, and all of that stuff. On the lab side of things, once we are sure that we are dealing with maybe CLL or a chronic lymphoproliferative disorder, and if the counts are high enough in the peripheral blood, I would probably go in just for a peripheral blood flow cytometry. Along with that, I'm lucky enough to work in an institute which has FISH capabilities as well as IGHV available now in-house. So and it's a reflexly done. So if the flow cytometry is done and it's consistent with CLL, they reflexly put up the CLL FISH panel for uh, uh, ATM gene and a TP53 gene mutation, and deletion 11q and a deletion 17p chromosome, and also reflexly put up an IGHV to look for the hypermutation if it's there or not. That may not be there in many cases, but most large academic centers now in India would be having at least this much of baseline investigations. Other than that, I do usually get an immunoglobulin profile and beta 2 microglobulin done at baseline. Some of the top centers do also do NGS. Uh, so, for example, to look at TP53 mutations in addition to just a del17p on the fish, as well as other markers. We have recently gotten an NGS in-house at PGI, so we've also started doing that for our CLL patients in some cases now. In
So,
addition to that, what I will say is, if the patient is really symptomatic and has prominent B symptoms or has maybe come in with a history that I've had this lymph node for the past 2-3 years, but now for the past 1 month it's been growing really rapidly. I would also get an LDH and maybe a PET scan to rule out a Richter's in these kind of patients, but that's a very rare thing, not a common thing.
so how do you approach treatment?
So. Uh, 50% of our patients would probably not require any therapy because they would not fulfill any of those criteria. They would not have any B symptoms, any massive lymph nodes which are either causing compressive or cosmetic issues, and no cytopenias. So these are the patients I would just counsel and tell them to remain on regular follow-up. Even in these patients, we do tend to immunize them at baseline. So I would immunize them for the pneumococcal as well as the influenza vaccine. The influenza vaccine is repeated yearly in these kind of patients. Additionally, I would, if the patient is able to afford it, I would want to give a zoster vaccine also in these patients. It's slightly more expensive to the tune of around 16,000, 17,000. So not all patients are able to afford it. So that's an optional thing. But if they are able to afford it, these are the vaccinations I will give to all patients of CLL at baseline, irrespective of whether I'm treating them or keeping them on observation for the CLL. Once it comes down to treatment of the CLL, if they do have a treatment indication, I think we've moved on to BTK inhibitors in the front line for most of our patients. So we are lucky enough that we have generic acalabrutinib as well as ibrutinib available to us uh, in India. Uh, I think there's a slide later on which will talk about Ayushman Bharat, so I'll leave that conversation for then. However, acalabrutinib, for example, is available for 15,000 rupees, which comes down to less than $200, if my calculations are correct, a month. That falls into the purview of a large number of patients, and that is actually, if you look at the 1 year cost of things, that's kind of equivalent to, say, a bendamustine rituximab kind of therapy. And now with the evidence which is there, which clearly shows us that BTK inhibitors are superior to bendamustine rituximab, I think BTK inhibitors are now my go-to therapy for most of my patients until and unless they have like a contraindication to them. So I would not want to give them if the patient has maybe a history of an arrhythmia, or maybe they have some heart issues with a dilated cardiomyopathy, and I'm afraid of an arrhythmia occurring. I would not give it. And there, I would prefer maybe a chemo immunotherapy based regimen, but otherwise, BTK inhibitors are what we are now going towards in the front line. Venetoclax, as you mentioned on the slide, so it was recently launched by AbbVie in India. It's still very expensive. So it's out of reach for, I would say, 90% or 95% of the patients which come to our practice, or my practice at least. We do use it occasionally. We do give the option to patients who we feel can afford it, but most of the times we're going with BTK inhibitors. I can maybe count on my hand the number of patients I've given venetoclax and CLL to frontline.
And do you have access to the next generation of BTK inhibitors, pirtobrutinib, and drugs of that class?
So zanubrutinib was recently released. So we do have zanubrutinib, which is available in India now, which is the innovative brand. Pirtobrutinib, unfortunately, is not available in India.
And do you still use chemoimmunotherapy in certain circumstances then?
Yes. So, but the it will go down to a patient who probably is from the lowest of low, probably socioeconomic strata, who does not have an Ayushman card or government support. So we will end up probably supporting through some NGOs or something, or maybe some in-house. We'll be able to give them a little bit of rituximab and bendamustine, and that's what we'll probably end up giving them. But that's now growing smaller and smaller because more and more patients are covered by the Ayushman Bharat scheme, which is the government health scheme. And like I talked about, until unless they have a contraindication to ibrutinib, that or a BTK inhibitor would be maybe the second place where we're using bendamustine rituximab.
So what
FCR I hardly ever use now. I've not used it in the past 3 4 years now.
so what kind of results should patients expect with these BTK inhibitors in terms of duration of response? What is the long-term prognosis of this disease?
I think so. The longest, what I will caveat my future comments about this conversation is that most of the results are with the innovator brands and not with the generics. Uh, I do think the generics work equally well, but we don't have long-term data published which shows that they work equally well. So that is the caveat to the discussion which is going to go on from right now. Uh, but what we do share with them is that at least we have from the resonant trials, we've seen that ibrutinib practically gives you a duration of or an overall survival which is equivalent to the general population at least. So we tell them that you can expect a really long duration of therapy, and that's where counseling really comes in. That you have to tell them that you know what, you're going to feel better, your hemoglobin is going to improve, everything's going to improve, but you have to keep taking the drug, and that can go on for 5 7 8 9 10 years, depending on how lucky or unlucky you are, in the sense that how long your CLL stays in control with this therapy. So as far as our own results are with ibrutinib, we did publish a small, I think 40 50 patient data from India, which is, I think, the only published data for India for ibrutinib. We found that obviously, like as can be expected, that patients who get it in frontline do better as compared to if you're giving it in the relapse refractory case, which was the most patients because it came. This was, I think, back in 2019 or 2020, maybe when we published it. So at that point in time, ibrutinib had just been released, and most of our patients were getting it in the later series. Now we are in the process of analyzing our patients because we now have a significant number of patients who have received BTK inhibitors in the front line, whether it be ibrutinib or acalabrutinib. We are in the process of analyzing our results, and hopefully we'll be presenting or publishing them soon.
And so you started hinting upon some of the challenges in the Indian context. So would you like to expand upon what issues you face?
So yeah, so late stage diagnosis, as you pointed out, often patients will just and this is not a commentary on, it's not their fault, I want to say. It's just that the circumstances are such that there are other pressing needs, and if they have maybe one odd lymph node here or there which they're feeling, they don't feel that it's worth the time to visit a doctor and spend the money for it, right? So often we'll see patients who'll end up coming with really like generalized lymphadenopathy, hemoglobins of 4 5 6, and they'll say that we've had these lymph nodes for maybe a couple of years, but we never bothered to get them checked up. At the same time, the awareness for general practitioners may not be as much. We've had cases, I can share, not in the CLL context, but in the Hodgkin's lymphoma context. Patients again having lymph nodes with some B symptoms, and they go to general practitioners. Maybe they do an FNA, maybe they don't, and a clinical radiological diagnosis of tuberculosis is made, and then they end up receiving ATT. They don't do get better, and then they come to us later on. So maybe 6 8 months down the line. So when we analyzed our data for Hodgkin's lymphoma, we found that nearly 10 to 12% of patients had received empirical ATT when they didn't really need it. And that may be true for CLL. We haven't looked at it systematically from CLL also, but that may be the case. Often, the person in the lab in the periphery and in the smaller cities and villages is a technician, and they're not a MD pathology who's reporting the CBCs, and as a result, they'll just not have a peripheral smear, and they'll look at the TLC and then say, "Oh, you have sepsis," and then they'll be treated with a lot of antibiotics for no reason because they may have a little bit of fever because of the CLL. So those are some of the things that are challenging in our scenario. Obviously, then beyond BTK inhibitors and beyond, I would say, ibrutinib and acalabrutinib, the others are quite expensive. So if we don't have pirtobrutinib, like I talked about, zanubrutinib is quite expensive, and it would be hard for, I would say, 99% of people to afford out of pocket. Uh, and venetoclax the same. So venetoclax, a month of therapy is going to be somewhere around 80,000, 90,000 to that in rupees. So that'll turn out to be around maybe $800, $900. It may not be much when you compare it to the US, but for a person who's earning in rupees and taking into consideration the gross national income of our country, that's out of pocket. That's really, really tough to do for most of our patients. As far as the real world data is concerned, I think here I would say that PGI and my colleague, Dr. Dipesh, who's also my teacher, has published extensively on CLL from PGI. He's now, unfortunately, a non-PGI. He's gone to Vancouver now, and he's practicing there. He's a part of the leukemia and transplant team there in Vancouver. But he's published extensively on CLL, and we published a real-world data experience of over 400 patients. We published a quality of life study on CLL. We published on ibrutinib in CLL, as well as financial toxicity and how we've had to reduce the ibrutinib dose because of finances in patients with CLL and had decent results. So we have, at least from PGI, we have a significant amount of real world data also in the CLL space, though it may be missing from other parts of the country. And India is a huge country, so there may be differences even in geography. So that is missing. You're right. But at last, as far as North India and PGI is concerned, we published extensively in the CLL space.
Yeah, you guys do a great job. I don't know how you do it with all the patient load that you have to,
No.
it's not any mean feat. So kudos to you guys. So as far as the support system goes for affordability, I think you hinted upon some of these things. And so how are patients able to be supported?
Yeah, so I'll talk about Ayushman Bharat first because I think it's really, really made a difference. Uh, when I started my hematology training in 2019, Ayushman Bharat was just starting out. It was in its first iteration, so it was not as encompassing about the diseases. The version it is in now, it's still not fully up to date, but I would say that it's really good. So for those of you who may not know, who are listening, Ayushman Bharat is a government-run kind of health insurance scheme where a family, if they fulfill certain criteria, are able to have an Ayushman card made. It's available for all people above the age of 70 now, irrespective of whether you're able to fulfill any other criteria of income, etc. Above 70, you can get an Ayushman card made irrespective, but below 70, there are certain criteria that you have to fulfill regarding income, etc. And if you have an Ayushman card, which is valid, then you and your family get up to 5 lakh of health insurance uh, per year. So that comes out to maybe, I'm not very good at that, but 5 lakh
Sure, sure. That's fine. Yeah.
Indian rupees. Yeah. So, and this is a cashless kind of health insurance. So you don't have to pay and get reimbursed. So you don't have to pay or make any investment upfront. So in it, we get most of our standard chemoimmunotherapies. So you will get your BR, your FCR, your rituximab weekly if you want to give, and whatnot for CLL. And so you also get R-CHOP, ABVD. So your standard chemoimmunotherapies you will get for the patient, and they'll get them free of cost. So that's really good. And we're able to treat more and more patients, which we were not able to do previously. Because of the virtue of working in PGI, I am lucky to have some really good social workers also in my team. And because of the name of PGI and the trust that is put in by the people and the government, what we are also able to do sometimes is that if we want to give, supposing in a CLL patient, a BTK inhibitor, we can write down a letter to the state government saying that, you know what, you have this package for. So the way it works is that there are certain packages for different diseases, and each package has a certain amount which you can allocate to. So, for example, CLL may have two or three packages which may range from around 20,000 to 40,000, right? So I can write a letter to the Ayushman Bharat team saying that, you know what, for CLL, the current therapy of choice is a BTK inhibitor, which is falling into the cost bracket of this package, which is for CLL. So can you just give me that BTK inhibitor? And many times they'll comply. So as a result, at PGI, we are able to give a lot of the patients generic BTK inhibitors through and acalabrutinib even uh, at no cost through the Ayushman Bharat scheme. And that's really helped us manage these patients and helped a lot of patients as well. So it's really fulfilling to practice right now with this scheme. Generic drug availability, as I've hunted to many times before. So the drugs which are generic and are easily available at low costs, we are able to give to a large, vast population. Whereas drugs which are not available generic and are only innovative ways, such as venetoclax or zanubrutinib, the number of patients who are on those drugs are going to be much, much smaller. Or really very, very low, because out of pocket expense is going to be is going to be a lot for these patients. And non-government backed health insurance schemes are they're increasing, but they're not increased to the extent that I would say more than 20% or of people have, or maybe 20% is also a bit higher, maybe even 10-15% of people have that right now. And even then, their coverage amounts are not very high. So maybe those will get exhausted if I wanted to give zanubrutinib, for example, in a few months, whereas it's a lifelong kind of therapy. So those are the real issues with it. Other than that, we do have I reiterate that the institute where I work, which is PGI, has it's a large tertiary academic center, which is of a really high repute in the region and in the country and internationally, I would hope. And so we have a lot of NGOs who would do regularly collaborate with us and then provide help to our patients where most of these other schemes are also not working.
So touched upon some of these things that you guys at Chandigarh have really, published in this area, but you also talked about the lack of registries. So to kind of just summarize, what would you say is the status of research and registries in India?
Yeah, so we know that there are a lot of global registries. So for CLL, I think there's the ERIC registry, which is there, which we wanted to be a part of, I think. But when you're sharing any kind of data, which is patient level at the global level, or with registries which are not there in India, you have to get so many additional approvals, including through the health ministry, which makes it logistically very difficult. So it's not very easy to do when you have to do all of that as well as balance your clinical work and also research work. But the good thing is that we have a registry called the HCC, which is the Hematology Cancer Consortium, which looks at many diseases in the hematological cancer space. So the CML, CLL, acute leukemias, lymphomas, even myeloproliferative neoplasms. So it's not an all-encompassing registry. It's a voluntary registry. So hospitals and institutes which want to be a part of it are then made to sign contract and then get ethical approval, and then they can share their data and then pool in that data. And then anybody who's a part of that registry can uh, suggest uh, a research project or maybe look at that data after the different centers approve of it and then can come up with these. So we are getting there for CLL as well, but it's not all encompassing as of right now. There are major centers who are still not a part of it. So we are getting better.
So what about awareness and education? How you mentioned that there are some lacunae in this regard.
Yeah, so like I talked about before, so basic pathological diagnosis of looking at a PBF may not be available everywhere in India. So you can get like a simple CBC everywhere in India, I would say, and you can get it very cheap because there are technicians in different laboratories which are present even in the smallest of villages now. And they'll be able to run a Coulter and tell you that, okay, this is the CBC. But once the TLC is high, that's where the interpretation ends. And here, because infections are so prevalent, all high leukocytosis is taken as an infection, and then they're pumped in with antibiotics. So that's an area where there's an issue. Secondarily, what also is an issue is that many times there's a resistance of patients to visit a doctor. So they'll end up going to the technician, going to the lab themselves, getting a blood test, following the technician's advice, going to a pharmacy, getting over-the-counter antibiotics, following the pharmacist's advice. And only when things start going south, then they start visiting a doctor. So I think there's an issue there as well, which needs to be addressed, which will get addressed, I think, with time as more and more awareness is being generated. But that is something that we still uh, face in India, and that's, I think, directly correlated with the education probably.
So a lot is
So
happening.
if you could go back to the
Yeah,
last slide,
yeah.
the point which you've written at the end is something really important. So advocacy to reduce stigma around cancer. That's something we face a lot in our practice. So we'll have, so like CLL is usually a disease of the elderly. So we'll have kids coming out into our chamber first, and they'll say, "Oh, don't reveal the disease to our parents," and we'll end up having to circumvent the cancer word. So we'll say, "Oh, in vernacular की TLC के कीटाणु बढ़ गए हैं," or yeah, as like cell बढ़े हुए हैं आपके in Hindi. So that's how we'll have to circumvent it, because the thought process of the family members is, you know what, no, they'll take too much of stress and that will bring them really down and they'll get depressed, and they won't be able to go on with their lives and so on and so forth. So it comes from a place of not stigma exactly, maybe stigma as well, but also just concern. But this is something that we see not only in CLL but many uh, cancer diagnosis. So again, it comes down to education and patient education, etc. as well. So I kind of make first have to educate the patient's attendants before I reveal the diagnosis to the patient many times. So that's an extra challenge in our setting.
So where do you see the field moving in India? What are the next steps, and where do you see yourself going?
So I think uh, we are moving towards more and more multi-center collaborations in terms of not only data collection, but hopefully research and trials, and then figuring out what's the need of the patient in the Indian context, and then designing studies around that. That is where we need to head, and hopefully where we are heading. As far as molecular diagnostics, I think before molecular diagnostics, getting a good PBF read at the periphery and the smallest to smallest towns should be our aim. And not we've been able to go to the extent that we have a a coulter present in the smallest town. Now we need to go ahead and say, okay, when the coulter is there, maybe we need a spike and hub model where we can say, okay, all of them, if there's an abnormal TLC or something, then that maybe is read by a pathologist or something. And hopefully we'll be able, and the government policies will be able to move towards that. And more generics really, and the cost coming down so that we can provide better care to our patients and can offer those drugs to our patients when they maybe want time limited therapy or when they progress on BTK inhibitors. Because right now, when you're progressing on a BTK inhibitor, you're going to have to rely on chemoimmunotherapy, which we know is not going to work for too long, even if it does.
So how would you, what is the message you'd like to send to the audience overall? Uh,
So like I said, I'm the audience. The thing I'd like to say is, like I say, CLL. Again, I always say that in my counseling session, there's a proverb in Hindi, "Naam bade aur darshan chote." So that's what CLL is. It's by name, it's a leukemia, but it's a chronic lymphocytic leukemia. It's not something that you need to be afraid of. It's many times you won't even need therapy. You'll go through life and you just need regular follow up. It is treatable, so don't be afraid of it, for the patients who are listening, or who caregivers who are listening, and for maybe the general practitioners who are listening, that a timely consult with a hematologist and an oncologist can put your patient's mind at ease and can help better manage them.
So I must say that I myself visited PGI Chandigarh and has been very impressed, with your state-of-the-art facility and your ability to deliver such great care to the patients despite limited resources, and then also find the time to advance the field. I first of all wish to congratulate you and your colleagues. As far as PGI Chandigarh goes, just to wind down, I understand that you're now also venturing into some of the forefront of therapies, may not be totally at the moment something that CLL patients has much benefit by, but things like CAR T cells, perhaps one day there will be bispecifics for this disease as well. So could you just give us a flavor for as far as your setup goes now, where are you with CAR T cells?
So yeah, so for CAR T, right now in India, we have two approved products for B-cell leukemia and lymphoma, which is CD19 targeting CAR T cells therapy. We were fortunate enough that PJ was a center for the phase 2 regulatory approval for one of those trials, and we've been after their regulatory approval, we have been using commercial CAR T now for the past 1 year at our center. We've been pretty happy with the results. We are also going to participate in a couple of other trials, including in the myeloma space for CAR Ts, as well as bispecifics, like you hinted towards. So yeah, the future looks really exciting, and we're excited to bring these therapies to our patients.
I'm sure you'll be at the forefront of all these trends like you've been in the past. And once again, thank you for taking the time to educate the audience. And I hope that I can rely on you to come back and talk to us about other topics in the future.
Yeah, it was a pleasure, and I'd love to be back to talk about more.
Thank you very much.